as we think about the treatment landscape, Katja, perhaps you could share with us your perception of what you've seen so far with both iberdomide, or IBER for short, and mezigdomide, or mezi for short, in terms of how they fit in the treatment landscape.
Yeah, so far it's interesting. Now they place a bit in the clinical trials. We look on that iberdomide was investigated now most recently more into frontline. We have very interesting maintenance trials, a huge EMN initiative. We have other maintenance trials where iberdomide is tested as a monotherapy or even in combination with monoclonal anti-CD38 antibodies. And then we have mezigdomide, even more tested now with the large phase 3 trials conducted in the more relapsed phase and in combinations. However, I have the impression this is also a bit mixing up, so this is not a true assignment to frontline and relapse disease for either or. However, I think we're expecting now the first data more in this space.
Got it. So relapsed refractory to start with for both mezi and indeed for IBER, recognizing that IBER is an early relapse, mezi is much different. Okay. And then there's movement into the upfront space for IBER with mezi really sweeping, as it were, across the relapsed refractory space. Now, one, I think, critical question is to think about tolerability profile. And I'd say, Thanos, as you and I worked very closely together in this space for a long time now. As you think about tolerability, what strikes you about both mezi and IBER?
With iberdomide, it is very important that we do not see the gastrointestinal effects, side effects that we see with lenalidomide, and also the fatigue. So these agents have as a main side effect neutropenia, which hematologists, oncologists know how to deal with. It's a short-lived neutropenia, easily reversible if you hold the drug, if you reduce the dose, even more so if you add a GCSF. So they have a completely different toxicity profile, which also explain the side effects that we see in both Excalibur and the successor studies.
So I think you make a great point, Thanos. I think it's a point of emphasis for our audience. Mezigdomide and iberdomide are both dose and schedule dependent. So I think it's very important to think about growth factor support as the first step in the setting of neutropenia, and to realize it's manageable and reversible, as you point out. And then dose reduction if necessary, yes. But certainly in the combination studies, as we've discussed before, it's very important to look at your partner drugs, isn't it? Because maintaining that dose and schedule of the CELMoD is absolutely key to its activity. So as we think about this, and these off-target side effects that we've been so pleased not to see, Rahul, in your experience with the CELMoDs, and recognizing in Seattle there have been some combination studies you've been participating in, what's your first impression?
Yeah, I mean, the points you both are brought up, all three of you are exactly spot on. I mean, I think shifting from side effects affecting every organ system, the joint aches, the fatigue, with lenalidomide, any side effect that could possibly happen. I've had a patient who's had it, all of us have. With iberdomide and mezigdomide, much more focused in the hematologic arena. I will say, we have a couple studies with iberdomide open, and I think that the neutropenia is a real thing that happens during cycle 1. I'd be curious to hear both of your thoughts. I mean, I think the mantra that I am teaching myself is to keep calm and carry on, right? Keep the GCSF going. I think a lot of times our instinct is to hold a dose, but often these patients in the relapse setting, part of the reason they're cytopenic is the drug, I'm sure, is working, clearing out the marrow, everything is kind of in flux. So if you are able to support them through it, use growth factors liberally, and get them over that hump, I have found that over time it does become more tolerable.
Yeah, that's an excellent way of describing it, Rahul. Thank you. I think the important point is it's a differentiation effect, not a stem cell effect. So it's quite safe to use growth factor, and in fact absolutely essential. The second thing is you raise a good point about when things are sort of bumpy to start with as things settle down. I think an important thing for people to understand conceptually is the antanomeric effect of these molecules as molecular glues is big. They go in and lock in, and they are large molecules. They sit there, they don't go off target. And that's a distinct difference to other degraders in the same space, and also, for that matter, the IMiD. So I like very much what you just said. And Katja, pivoting back to